screening conversation and handoff. That's crucial. But that's what we're looking for. We want hygiene to screen and then do the handoff. So one of the topics that I want to bring up to you guys tonight, kind of the main topic, is called hero positioning. And we're going to get into that in a minute. But I want to dive a little bit deeper on that hygiene visit as we're talking about screening specifically. Because again, if we're screening patients and we're getting them to the point of they've been tested and they have a CPAP that they don't use, they need an oral appliance. Or they've never been tested, they need a test. That's still all screening. But if we're screening in the process or in the practice, pardon me, one of the crucial things that you're doing, most likely without knowing it, is you're building trust with your patient. Now, before I get into this, I'm going to ask you, think with me, if you're in a GP office, think with me what your hygiene check looks like. Now, I'm not talking about the 15 to 20 year loyal patient that's been coming for that long and you walk in and have a backwards high five with a kick flip because you guys are besties. That's not what I'm talking about. Let's go with your regular patient who's not your best friend and you're walking in and you're going to talk to them. What do you physically do? When you walk into the operating, you're on the right or the left side. Where's your hygienist? Are they standing or are they sitting? When do you sit down? At what point do you converse with the patient? You see, this conversation is one that we actually go through in our weekend course once a month. And I have to tell you, the answers are almost always the same. I mean, they are so close to the same. Some people will walk in, the side is different depending on what hand you are, all that stuff. By and large, most practitioners that we've worked with walk in, they will address the hygienist, they will sit down, sit the patient up to have any depth of conversation, and eye to eye, knee to knee, they start conversing with the patient. So if there's x-rays you're going to go through or a cone beam scan you're going to review on a screen or something like that, you're sitting down conversing with the patient. What you're doing without realizing it, if you do that in your office, is you're shortening the distance between you as the doctor and the patient. See, they walk in knowing you know more than they do. You're a doctor, for crying out loud, and they're coming to you for your opinion. So if you're standing over them and they're laying back in the I'm going to die as an animal position, right? I mean, that's the dog submissive position. That's not a position of confidence or comfort for your patient. So you sit them up, you sit down, and now you're talking almost as peers. And the better you are at using plain language that they understand and utilize active listening skills, the more you are building trust without actually saying anything about it. So eye to eye, knee to knee, you're discussing things with them. And then if you notice this provider in this picture, yes, this is a stock photo. No, you probably don't pull your mask down. I get it. You can critique this later. But let me tell you, they're shoulder to shoulder. In the communication aspect, you want to talk shoulder to shoulder about something else when you're communicating anything to the patient about their care. Because what are you doing? Psychologically, you're putting yourself and the patient on the same side, and you're discussing something in common as you dialogue about it. You see, eye to eye can either be connection or confrontation. And the only difference between those is if you're on the same side of the conversation. That's connection. If you're not, it's confrontation. So the best way to communicate something external to the patient or talk about findings like is shown here, you're shoulder to shoulder pointing, showing them something, discussing it with them, and you're on the same side. So as you do that, let's talk a little deeper about this conversation. What are these threads, if you will, that weave through these conversations that are so connected with patients? Well, I would argue that one of those components is we need to understand who the hero is. Now, if you guys want a book recommendation, this gentleman here, Donald Miller, is an outstanding author and speaker. He wrote a book. He wrote several books, but Building a Story Brand was one of his first in business. And it's basically the 21 components of, the 7 elements of great storytelling that have an impact on your business. He identified 21 components of every great blockbuster movie that exists from a screenplay standpoint, and he adapted that to these 7 key elements that will actually grow your business. One of them, if you look at the first one here, is identifying who the hero is. And I know we can't talk back and forth, but to spoil the surprise a little bit, it's not you and it's not us. It's your patient. You see, every time you talk to them about something, the authority is assumed that it is in your hands because you know more than they do. After all, they're sitting in your chair, in your practice, and you're the doctor. But ultimately, they are the person in control of their outcome. If they don't floss, what happens? If they don't brush their teeth, what happens? If they don't do what you've told them to do in preparation for the surgery they're coming in, what happens? Or even better yet, what we've talked about tonight so far, you present clinically appropriate treatment that could potentially save their life or at least make it infinitely better right now by sleeping better. And what do they tell you? I'll think about it. Who's in control? The patient. So if we can identify them as the hero in their story, if you will, we also have to communicate what the problem is, and we'll get to that. But you've also got to know your role. If you look at number 3 here, the hero meets a guide. And if you all like Star Wars, awesome. If you don't, deal with it. It's one of the most iconic pop culture references we can pick. Luke Skywalker is the obvious hero. But who's the guide? Obi-Wan Kenobi, maybe Yoda. Again, if you guys don't like the series, it's fine. The more masterful Jedis that know more than the hero are the ones that know more. They're the teachers. But the main character in the story who actually has control over the outcome is the hero or the person themselves. So I know it sounds a little bit cheesy, but please understand, in order for patients to take action, you're going to have to help them understand they are the ones in control. The more we can communicate in a way that we empower them to take that action, the more results we're going to have, the more yeses you're going to have. That is an absolutely crucial part of this. And that, frankly, if I had boiled all of tonight into one goal, it's this slide. How do we do us better to empower our patients to take action? Yeah. Todd, what do you got?
Yeah, I'm wondering, and you might be covering this, Michael, but do you guys provide some sort of like conversational template where you say, here's the path of these conversations that helps patients feel empowered? Because I've heard, I've talked to a lot of sleep practice consultants and things like that. Mm-hmm. And one of the things that I've seen that's incredibly effective is asking people a question that they can relate to something a lot more simple than sleep. And because sleep is often something that's very hard to connect the dots to. If it's just like, hey, I can live 7 years longer, I don't feel immediate pain. But if you say, hey, for example, you're shoulder to shoulder, eye to eye with the patient, you say, if you go to the mechanic says, you got about 20 miles left on your brake pads, would you agree that brakes are important? The patient says yes. Okay. Yeah. Would you agree that if you don't take care of this, you're probably going to cause an accident, harm yourself and others? Absolutely. Would you agree that it's important for us to replace these brake pads? Mm-hmm. Absolutely. Do you guys have conversational patterns like that you walk people through?
We do. And one of the things that I've seen work over time, we're actually going to tonight, the next few slides here, we're going to go through 3 specific steps of how to weave this into the conversation.
Nice.
Okay. What I have seen over time is hard scripting is an okay reference point, but so many times, and guys, if you've tried this in your practice with another group or another consultant and it's tanked because you try to use the exact script and memorize it, and your team sounds like a robot in a bad audition for a screenplay role, like we got to humanize this.
Yeah.
So Todd, to your point, yes, we can absolutely help with that. But I think at the core, if we understand as you guys as providers, as doctors on here, your team as support structure for you and the patients, the more we can learn how to communicate in ways, the principle behind the scripting.
It still needs to be dynamic, essentially.
Yeah, absolutely.
Okay.
We got to do that. I mean, candidly, if you had the same call script every single time you get on the phone, someone knows you're from a call center in like 10 seconds max, right? Because we've all had those phone calls. You're like, well, hold on a hot minute, man. I just asked you a question. You're reading the next screen. That wasn't your correct prompt. Like, no, active listening is crucial.
Yeah.
And that sounds cheesy, and I kind of don't care because it stinking works. For y'all that are married, you want to have some brownie points here, go home and practice active listening to your spouse. Telling you, it absolutely works. We just get stuck thinking too much instead of just receiving when someone's talking. So anyway, we'll get into that.
Cool.
Did that, Todd, that answer the question?
It does. Yeah, I'm excited to keep going here.
Cool. All right, so I promised you 3 steps. Let's talk through them. How do we do this? Well, the first thing is we need to separate the patient from the problem. If they are stuck, meaning they believe that this is who they are, not what they're dealing with, who versus what, that's point critical. So the first thing is we got to separate the person from their problem. Second thing is we need to reconnect them to their emotional pain points. That's going to be a whole conversation in and of itself. The third component is we've got to clearly communicate a positive alternate outcome. And I'll show you guys what I mean by each one of these. The first one, how many of you, and I'm actually going to ask you to respond in the chat with this one. How many of you have had a patient, just give me a 1 or a thumbs up if you've had this. You've had a patient that walks in and they know beyond a shadow of a doubt, they have never been the problem. Not once in their whole life. Not in any conversation, not in your office. They're never the problem, just ask them. Okay, yeah. Lori, it's not okay to say that about Tony, okay? He's the doctor after, I'm just kidding, Tony. Yeah, you're gonna have some folks that do that. They know for sure they aren't the issue. Well, they just checked step 1 for you, right? You're also gonna have people like my bride who walk in and automatically assume that they have to own every problem that exists because their primary focus is to make sure everybody's happy. Do you guys know some of those folks? You have some of those patients. They're so sweet. They'll give you a cavity. They really want to make sure that everything is fine. They'll apologize first and then figure out it wasn't their fault second. Those folks exist too. And then there's most of us that are kind of in the middle, right? When you have patients that assume they are the issue, we have to address that first. Let me give you an example. If you have a patient that you're screening for this and you let them know, hey, I see a lot of stuff on your health history that looks like what other patients in the practice with a similar history have suffered from stuff at night. I see that you're really tired and that you snore. How long have you been dealing with this? Oh, well, hey, everybody in my family, we're either hypertensive or diabetic. And for sure, by the time we're 45, everybody in my family snores. That's a male and has lived that long. That's just who we are. Well, can that person fix that thing? No. Well, I'm just this way. This is who I am. This is how I operate. Hey guys, that's flat out. If that's the statement, that is a 100% red light. It doesn't matter what the conversation is because they don't see a path forward. It's part of who they are. So in order for them to address it, we need to detach the problem or separate it from the person themselves and realize, oh, there's something that is attacking me. I need to overcome that. Now, again, attacking is a little bit of a strong word, but personally, I like it. I'm okay with that conversation. Some of you might not be, and that's all right. But what if you talk to a patient that's suffering from snoring, that's dealing with morning headaches or things like that? Let's go with morning headaches for now, because we'll take that through to the next slide. What about that patient? What about when you're talking to them and you say, has anybody ever talked to you about the fact that your airway might be attacking your sleep at night? Has anybody addressed that with you? I wonder kind of the like single, I can't raise one eyebrow, but single raised eyebrow looks you're going to get for that one. So you ask the question, has anyone ever said this? No. Why? Well, because many patients that we've seen in this office that have this backstory or health history and things that I've identified in your mouth, I see this, I see this. I got to ask you how you're sleeping, because I care about you as a whole person. That's how we treat people in this practice. But you're looking at the problem with them. Has anyone else ever talked to you about this? No. Why? It's that rebound, that spring into the conversation. Well, because this is what I say, again, shoulder to shoulder, this is what I'm saying. Other patients, not you, have this issue. Other patients who have these things, these signs that we observe in their mouth, these are indicative or indicate that there may potentially be an airway issue. That's why I asked you. Oh, cool. Next. But that's separating the person from the problem. So if you want to use that as a launching pad, has anyone ever asked you if your airway is attacking your sleep at night? If you don't like the word attacking, you can substitute it. Has anyone ever asked you if your airway is affecting your sleep at night? Word choice matters. If you're reacting to the medication, is that positive or negative? It's negative. If you're responding to the medication, positive or negative, it's positive. Word choice really matters, but you got to be comfortable with your word choice here. I like attacking, you can use affecting, but that's one. Has anyone ever talked to you about your sleep and how it might be attacking or affecting, or your airway affecting your sleep? Okay, separate the person from the issue. Step one is complete. Step two, how do we connect their emotional pain points? Does it feel like your patients have this many emotional pain points? They're just kind of a powder keg sometimes. Be careful with that. Obviously, there's a reason why people have these triggers, right? Let's say you're talking to, well, I'm just going to ask you guys, since you've been doing this, have you ever, give me a thumbs up or a one in the chat. Have you ever had a patient that you talked to about sleep and you thought your life might be in danger or they were going to take your head off? Have you ever had that? Come on, Tony, I know you have. Joseph, yes. Why? You don't usually get that for oral cancer. Now that's less prevalent. It still kills people, unfortunately. Tony said he's still healing. Yeah, Michelle, you too. So why would people do that? Well, maybe that middle-aged gentleman for the last 10 years wakes up almost every morning to a crabby wife who reminds him incessantly that he is the reason why her life is difficult, because she can't sleep since she married him. That's a tough one. Or he went to a sleep center and had an awful night of sleep and then got into a CPAP machine that since has been recalled, and he didn't like the mask, and now he's got a machine that still isn't fixed, and he can't figure, oh my gosh, if somebody else talks to me about the way that I snore or how I sound when I sleep, I'm just going to punch him in the nose. You might be the next question there. So we need to be cautious, or considerate, I should say. Let's be considerate. But at the same time, guys, what they're doing is tipping their hand. Let's take a step back from the assault, verbal assault that you experienced with that heck no type of a patient. What hurt? What's the problem under the problem? The problem that that gentleman would say is that he has a wife that doesn't know how to not complain. Well, that's not really, that might be the symptom, but that's not the root cause. The root cause is neither one of them have slept for a decade, because he's been snoring and having apnea, which breaks up his sleep pattern, drops his oxygen, does all the things that you guys know it does. Well, for her, she's got secondhand snoring. She constantly wakes up and can't function during the day because she's stuck sleeping in bed with somebody that keeps her awake all night. Or she's terrified that he's not going to wake up in the morning. She's going to wake up to a dead body. So she's constantly elbowing him, and sore rib syndrome is the way that you're going to screen that guy. When you hear pain, that is the spot that you need them to connect to, not to harm them, but you need to connect the patient to their emotional pain points for the purpose of using it as motivation to move forward with something. This is different in cosmetics, but this is not cosmetics, guys. This is medicine. Your patient that walks out with apnea, with heavy snoring, severe apnea, moderate apnea, whatever they have, maybe they're not diagnosed and they just know they're not doing a test. That person who walks out is still suffering from this and still has the potential to put themselves and other people in harm's way. Todd, what's up?
Yeah. So I'm wondering, obviously a lot of the questions in the Q&A when we had people type in there were about money objections. And I'm wondering, is there a way to connect these emotional pain points so that the money is not an issue? Does it, like, the emotional pain point might be like, hey, like, I can't get enough sleep, but I can't get enough sleep to want to spend $3,500.
Yep.
At what point do you connect enough emotional pain points for them to see it as valuable enough to invest in?
I wish there was an emotional pain point calculator,
Right.
like arithmetic, that said, if you do these 5 things, they're going to say yes. The truth is, everybody walks in a different part of their learning ladder journey. If you screen someone for the first time, they have no idea what they don't know. They don't know what they don't know. Yeah. Then they have to get to a spot where they're afraid of what they don't know, like that progression. So each patient is going to come into your practice or this conversation in a different frame of mind. So figuring out a framework of how to meet them where they're at. Like, guys, let me be clear. The person who is already upset that wants to take your head off, I would strongly recommend that you do something to the effect of physically pull back just a little bit, but conversationally lean into what they just said. Drop the tone of your voice, be slow, methodical, calm. You're bringing calm to their storm. Hey, Earl, I have no desire to upset you today. I'm your doctor. I'm trying to do my job here. And it sounds like that's really frustrating. Label the emotion. Physically step back, conversationally, calmly, lean in, label the emotion. That sounds really upsetting. Did I do something right now to upset you? Well, yeah, you stinking talked about this. Okay. Is that the first time anybody's talked to you about that? No. In fact, tipping the hand. This hurts. Hey, you know what? We're not here to push, Earl. Listen, someone in your circumstance, other patients that have had this, again, shoulder to shoulder, talk about something else. Other patients that we've seen have these types of signs or these types of conversations. This is what they've gone and done. And this is what was really the underlying thing that was going on. Hey, you know what? We're not here to push, we're here to help. But, you know, I would strongly encourage, if you want to, I'm happy to talk to you about this. If you want to talk to your doctor about it, I would really recommend that you do this next step, whatever that is. If it's a home sleep test, if it's a consult with an MD, this next thing needs to happen. I'm your doctor who cares about you. This is my job. And I'm not going to not do my job here because I care for you.
Yeah.
But and this is getting into the next slide here, Todd, but to really, man, you put a quarter in the machine. This is my jam right here. But this part though, I do want to connect with. Ask the next question. Sounds like this is really hard, painful, upsetting, frustrating to you. If there was something that you could do to stop that from happening anymore, would you want to know more? Yeah. And the answer is always yes to that. If you can say it in the right frame, this is fill in the blank. Hard, painful, difficult, frustrating, whatever. Would you want to know more if you could figure out how to not have that happen again? Maybe Earl doesn't want to ever hear his wife complain about how much noise he makes again. Fantastic. But Melissa would do anything to wake up and not be in pain in the morning, because almost every morning, 4 or 5 nights out of 7, she wakes up with a medium to severe headache and she's fighting through pain, getting ready and going to work and getting her kids off to school. Like, again, stereotype, but these are stories. These are real people's lives.
Yeah.
Would you want to know more? If this could be alleviated, would you want to know more? And if you can frame it the right way, the obvious answer is always yes.
Perfect.
If it's no, Earl, no problem. I got to write down that you know, there's a refusal to talk about this again. I'm not going to push it here. Just to let you know, in 6 months, we're probably going to bring it up. We don't have to talk about it then, but this is our job. We just need to get you to the next step, because clinically that's what's appropriate.
Are you just letting them know that you're obligated to monitor them, like ADA says that you should be screening for this? Yeah,
absolutely.
Okay.
And that's Todd, to tie into last time. That's a lot of what we covered last time, right? The ADA says that you need to be screening and working with physicians if you own tests or want to. The AADSM says that, hey, you know what? We're the perfect provider to hand out these tests and have a sleep physician read these tests for you. This is us doing our job. And by the way, docs, you don't owe your patients an apology for that. They should be high-fiving you for doing good work. But if it's a pain point, you don't have to apologize for being the doctor. Just take a step back from pushing on the button that hurts and see if there's any way we can get them to the next step by saying, hey, let's figure out how to alleviate that.
Okay.
Cool. All right, let's keep going. See, it's all about cheese tonight, guys. We got Superman in our hero positioning. The third step, this is absolutely critical. We need to be able to communicate a positive alternate outcome. Patients that are chronically sleep deprived are one of the most at-risk populations for not being able to be self-aware of what's going on with that sleep deprivation. Acute, notice what I said, chronic sleep deprivation is one of the most difficult things for patients to be self-aware of. Acute sleep deprivation is so painful, everybody knows it exists. How many of you guys have ever stayed up for 48 hours straight? Anybody in the chat? Give me a yes or a no if you don't mind. Let me see that you're still alive here and and kicking. Anybody stayed up for 48 hours? Yes or no? Yep. Oh, Todd, you're a 3-upper, 51 hours. Yep. Okay. At the end of that time, your fingernails hurt. Your eyebrows hurt. Like, if you could just stand somewhere and close your eyes and lean against a wall for 4 minutes, the world would be perfect for a quick second. Like, you're doing everything you possibly can to get sleep. In fact, and everything seems fuzzy. Yes, or funny. Yeah, it's wild. But see, our brains in acute sleep deprivation, man, you feel it. And your brain's going to put you to sleep anytime you're in a comfortable, climate-controlled spot, like a vehicle, not doing anything but minimal fine motor coordination and eye focus, that's a bad one. But our brains are going to grab sleep wherever they can. Chronic sleep deprivation that stacks up over time, your brain starts to function like we're actually in this state of homeostasis or balance when you're sleep deprived. That's what apnea is. I don't know if you guys have ever heard the definition of apnea that way. Yes, apnea, it's a 10-second, it's a 90% reduction in airflow for at least 10 seconds or longer. Yes, check the box. We've all heard the course. Translation, your brain understands the exact split second you stop breathing properly while you are sleeping, and it allows you to go 1 second after the other at a time in order to stay asleep for those seconds. It's so sleep deprived, it's trading oxygen for sleep 1 second at a time. That's why a lot of people that are intelligent are trying to change the severity levels from AHI to hypoxic burden, because they understand that longer apneas have a bigger dip in oxygen, which has a bigger impact on our systemic health, overall inflammation, everything that hypoxemia does over time. So that's huge. Pulling it back here, if patients can't be self-aware of this, how do we communicate this? Well, find the pain points from before. Let's take Melissa again. She wakes up and she's in pain. Let's call it at least 50% of her mornings. So 4 days a week, she wakes up with a headache. She's got to fight through pain on her way to her day if it doesn't take her out completely. That's one. Number two, she's always tired. In her afternoon and evening, she's got energy for zero. Making dinner, getting the kids in bed, oh my gosh, that is a feat like climbing Mount Everest. I've got nothing left. So her life is spent waking up in pain, getting everybody off to their day and into her job. And then by the time she has any time for her family or herself, she's on empty in her gas tank. Does that sound hard? That sounds like she's surviving her life. Well, what if we created or communicated a positive outcome, a different or an alternate example for her? You have to communicate it, because someone who's been in that spot for years doesn't even know that it exists. Hey, Melissa, what would it feel like? What would it feel like if, insert the blank. What would it feel like if you woke up without a headache? Do you remember the last time you woke up without a headache? Like zero headache, no pain. You just woke up and you felt refreshed. I don't remember how long that is, Doc. I don't know. I'm either in pain or I'm groggy. I don't know what that feels like. Okay. If you woke up with no pain, you felt refreshed, like you didn't even need coffee. The sun was up. Hey, let's get the day started. We're going to go. What if you woke up feeling like that? How would that change it? Oh my gosh, that would be amazing. That would feel amazing. Wait, we just turned hard, frustrated, upsetting into amazing. What if you worked the whole day and you felt fantastic? And then when you came home, you had energy for the kids. You might even have energy to do something for yourself in the evening. What would that do? What would you do? I would take a bath and read my book that I've been wanting to read for a month, because whatever, guys, those details, remember, I said the script is only going to work if you humanize it. Connect to your people, ask them good questions. But remember what I said earlier, you're going to take a step back, lean into the conversation, but physically step back to bring calm to them. You're going to label the emotion. Well, let's get them to label what the positive alternative would be. Now we have the pain of where they're at, that is motivation to get them out of where they are. They're not identifying like connected with this thing. It's a challenge for them. That was step one. Now we've got their emotional connected pain points. So that's the motivation to get the heck out of here because it sucks. And then the last piece is, where am I going? Oh, I'm getting out of here so I don't have to wake up in pain every single morning. I'm getting out of here so I can actually live my life instead of survive my life. That's motivating. So, is this just my idea? No. Let me show you. This is a website. If you guys want kicks, just to goof around, iSpot.tv. These are pharmaceutical videos based on topic. Notice the names and the images. These are the osteoporosis, bone density, arthritis medications. Do you see anybody that looks crippled? Do you see anybody that looks like they're not walking well? We're doing dancing and yoga in the park. There's one called zip lining. Pharmaceutical companies are smart because what are they doing? They're selling the future, right? They're selling this. The osteoporosis Boniva medication to address osteoporosis and osteopenia. They're going to have a mature couple on mountain bikes on the top of a mountain at sunset, not sweating, totally happy. And I mean, you know, this is what they're going to play. Why?
And
Because
helmets unbuckled, which means they're okay taking risks.
they're selling the dream. They're selling the vision.
Right.
Guys, they're not putting the needle in somebody's arm because some of these medications are injection only once a week. That's not what they're doing. They're showing them the next step. They're showing them the outcome of where can you go if you just took this medication, then this is what your life could be like. Now, they're not actually saying that, but that's what they're saying in the imagery. Now, please do not hear me wrong. I am not telling you to manipulate people. Please don't do that. But what did Todd say when we first started? It's our moral obligation to sell the best way that we can, or let's change the word sell, since that's so offensive to so many people. It's our job to stinking communicate in the best way possible to get our patients, your patients, to take action. Now we're going to address money. For those of you guys that like everybody put money in here as a main objection, we're going to get to that. And yes, we'll talk about building value. But let me be clear here. The more you listen to your people, the more you can use subtle things like, has anybody told you your airway could be attacking your sleep? Or that sounds painful. That sounds hard. Label the emotion. And then do the inverse. When you're communicating this option, that would be amazing. How would that make you feel if you can do things like that with people? What are you doing? You're building trust. You're connecting with them. Ultimately, you're listening to them. They're by and large trying to tell you what you didn't know you needed to hear. If they're telling you no, they're telling you what matters or what didn't connect. Money only means that there isn't enough value created. It doesn't matter what you're charging or what you're selling, whether you do an insurance or fee for service. Because I got to tell you, and I'm guessing, I can't see your faces, but I'm guessing at least two of you rolled your eyes at me right now. That's okay. I'm not offended. But let's put it in real world terms. You guys have had patients that tell you no for a $2,000 deductible or a $3,500 treatment plan or whatever. I see all the answers in the Q&A. So somebody has told you no for money. Whatever that dollar amount was they told you no for. Imagine your child needs heart surgery and that's your copay. Is that an option? Imagine your kid they were playing soccer and they broke their femur in 4 places. And the only way they're going to walk normal without a limp is if they get that orthopedic surgery. Is that dollar amount optional? No. By and large, the answer is no, because the end outcome that's not positive is too expensive. So the dollars are less than the expense that's perceived. So in our scenario, part of this is us connecting with patients. It's you listening to them as they show you what hurts, as they tip their cards, if you will. listening to that, and then using that in your conversation to build trust, communicate value to them, and then really align why are they willing to do this. The what isn't in question. I'm going to guess that no one has come to you and said, you're a quack, you don't know what you're doing. I know how to make an appliance and you don't. I'm not getting it from you. That doesn't happen. By and large, that doesn't happen. What you will get is it's too expensive. I don't have the money. If my insurance isn't going to cover all of it, I'm not going to do it. My deductible's too high. I don't know that I want to do that. I'll think about it. You're going to get a variation of all that stuff. What we've ultimately found is that the value we're creating, the pain points we're connecting to, and the outcome we're communicating has not aligned with them enough where not doing this is more expensive than doing it. Every single patient that you talk to will say yes if they understand that not doing this is more expensive than doing it. That's a little tongue-in-cheek and easier for me to say on a webinar to you at what, 8:55 Eastern, 5:55 Pacific tonight, right? Easy for me to say. But if you're honest with yourself, and I'm honest with myself, the truth is it's accurate. Every single person says no because we haven't found the thing. We haven't found the thing we can do to fix the problem that they have, or we haven't communicated it well enough. That's it. So that is crucial in this process. So in summary on those, 1, separate the person from their problem. 2, reconnect their emotional pain points. And 3, give them a vision. Communicate a positive alternate outcome. Those are the 3 things. Now, I see some questions coming in. I'm going to hit these last couple of slides real quick, and then we'll get to those. Todd, is that okay?
Yeah, that's good. I just saw Tony posted in the chat something real quick about saying who's going to miss you the most after you die. I was going to say we've had sleep coordinators at offices that we work with ask that question, but they are very, very tender in communicating that question.
Yeah.
Because it can sound facetious, like it's like, fine, you don't want to do this. Who's going to miss you most when you die? You know, you don't want to be that. You don't want to communicate that way. So it has to be coming from a place of tenderness and concern. Yeah. And the patient, you should have been able to build enough relationship with the patient to be able to ask a question like that. So just be cautious with it.
Yeah.
Having a Southern accent helps. So
I don't know.
Sweetheart, who's gonna miss you most when you die?
Yeah.
Like all right. I'll let you finish up, Michael.
Yeah, to Todd's point, that tenderness, if you're coming from a place of connection and you're already connected with the patient in this conversation, awesome. If it at all moves to confrontation, escalating during confrontation only creates an argument. So don't do that. And Tony, it's a great question if it's asked in the right context. So let's talk about this in the application example, home sleep test versus a PSG. Let's say, just as the example, you've got a local sleep clinic that you can refer to. It's going to take 2 to 3 months to get in for that. Or you have a home sleep test that you already own and you can hand it out to the patient today. Which one do they want to do? Well, that's not the first question. What are you testing for? That's the first question. We covered that one last time. But prior to that, why is the patient willing to be tested at all? Well, has anyone ever talked to you about the fact that your airway might be attacking your sleep? No, why? Because this is what I'm saying. And do you ever wake up with a dry mouth? Has anybody ever told you that you snore? Oh yeah, all the time. You ever wake up with morning headaches? Oh my gosh, yes, 50%. Oh my God, 4 out of 7 nights, oh my gosh. Cool, found the pain point. Well, at this point, based on the ADA and the ADSM, it's my clinical recommendation. I need to refer you for a test. So I see enough here where I'm concerned as your doctor, as your dentist. Let's go. Here's the next step. Would you prefer to go to an in-lab test or do a home sleep test? We have those here. We can hand those out, or there's an in-lab clinic I can refer you to that's down the street.
Yeah. Michael, would you show a picture like this to the patient? Like, there's a couple options for us to move forward. We can do an in-lab sleep test. It is obviously it's at a location that you're not familiar with, but it is a very accurate test. We can also do this at home and show them the difference, and then ask the question, which one would you prefer?
Yeah.
Okay.
Yeah. In a consult, yes. In a hygiene exam, no.
Right.
Because in a hygiene exam, you got to be
You
quick.
wouldn't have all your presentation tools in a hygiene chair.
Exactly.
Okay.
Yep. So in a 15-minute sleep champion consult, ideally, 100% yes.
Okay.
Yep. So that's something that I would show.
Okay, cool.
And again, it's not to say that the PSG is wrong. It's just comprehensive. So the reason why they're testing is the main take home here. So it's getting from something's attacking your sleep at night. We've got to overcome that to get you better. Sleep definitely affects these aspects of what you've communicated are in pain right now. We need to find out if there's an underlying root cause of those symptoms that you're feeling. Clinical fact. How would you like to get tested? That's their option. So that's an example from a HST versus PSG. What about treatment? Let's do the second example. What about treatment? Well, they got a lot of options. Candidly, in your consult, I would recommend that you talk about all of them. Not every single surgery, don't get me wrong. We have an hour-long treatment planning aspect of our course on the weekends that we go through a bunch of surgeries and oral appliances and CPAP, APAP, BiPAP. You don't have time for that in this, right? But in your consult, post-test results, you got a patient that comes in with a test, or you've done the home sleep test, and now you're sitting down and you go over those test results so they know they have this. How bad is it? The next question is, can you help me? Well, sure. I can refer you out for surgery to an ENT or for CPAP to a sleep MD who's going to script this. Here's what those options look like roughly. Or you can do an oral appliance. Now, the sleep physician who read this test, they recommended an oral appliance. I'd be happy to talk to you about some of those and how they work. And this is what's going on. This is what I do. But I want you to commit to taking doing nothing off the table. Because frankly, you could just do nothing about this today. That's an option. You know it, I know it. It's not going to cost you dollars today. But what is it like fast forward 5 years and every morning you wake up, you're dealing with a headache to a migraine? How much more of this can you take? If it's connected, God forbid something happened to you, who would miss you most if you died? We don't want that. In patients who have this at your level that don't do anything about it, they die 7 to 10 years younger. They have a 500% increased risk of cancer growth, and they have X% higher risk of heart disease, stroke. I mean, there's your list. You're not trying to scare people into this, but guys, this is why it's more expensive to not get treatment than to get treatment. And you know what? If you scare them a little bit, fine. That's not the goal here. The goal is action. But you know what? Some people like me, they got to hear sharp. And if you don't tell me straight up what it's going to cost me, I might not be listening. You might scare me into a CPAP because that's cheaper from my insurance, and I'm not going to do an appliance with you. Okay. That's usually a 90-day boomerang, as long as you're actually calling me to see if I got my CPAP and I'm wearing it. We want to be people's advocates. Be the signpost. Do the right work. You're not shoving an appliance in somebody's mouth because that's all you do. No, you're part of their treatment plan. If they're sitting in a consult with you, they expect a holistic consult. Please do it right. Tell them they can go to an ENT and look at surgeries that are expensive and painful, but they might fix it. Emphasis on might. Talk to the ENT about the success rate of the surgeries they recommend. Here's CPAP. It works for everybody that can keep it on their face. Can you? Will you wear it? Have you tried it? Here's what an oral appliance does. This is what we do. Here's the pros. Here's the cons. Here's why people rave about it. Here's sometimes how people can't wear it. Most people fit in the category where they wear it long-term, 83%, blah, blah, blah. Start quoting some stats. All I'm asking you to do today is something. Let's throw doing nothing away. You commit to doing something, and I will walk the path with you and be your advocate, because I'm here to help you in this process. Path of least resistance tells them psychologically to do an oral appliance. 1, because it's recommended by an MD. 2, it's the least invasive option possible. And that's
I really like what you said there about, in talking to the patient, let's take doing nothing off the table, because I'm really concerned about you. I'm concerned about your family. I'm concerned about your future. Which of these options do you think would be best fitting for your lifestyle, for your future? I think that's and logically, mandibular advancement, is probably the easiest solution for them.
Yep. Yeah, it is. And I mean, guys, ultimately, that's what we got to do. What's at stake? And I know those are gross pictures, both of them, hate them. The truth is, what's at stake stinking matters. Do you think with my story and my Anna at 5 months old, turning blue in my arms as my infant daughter, that I would not have spent every dime I had at my disposal to fix whatever she had?
Right.
Not even a question. And we don't need to be melodramatic or forceful or manipulative in this. That is not the point. The point is, people are hurting with this. They're suffering and they don't know it. And nobody's talked to them. Or the only solution they thought they had sucked, or really it blew a ton of air in their face every night and they couldn't hack it. So their life is terrible, because they either get eviscerated verbally by their spouse because their spouse can't sleep and they can't sleep, and they're in a different room. They love their wife or they love their husband. And this is traumatic for them. They don't have to live like that. And they won't live as long like that. So if we don't tell them, who will? That's a big deal. So for time's sake, I'm going to move us into the Q&A. Hopefully if my mouse works here, that would be helpful. Watch, it's frozen for a second, then it's going to yep, I knew it. Sorry, guys. So we're in the Q&A. I want to hit, we do have our discounted offer for you guys for the course. So I want to hit that real quick, and then we'll move into the Q&A. Awaken2Sleep does courses. We have one that is a weekend course, 2 days long, 14 Cs for you and 4 team members. If you have them, you can bring them for free. Your ticket is on sale, $597. It's August 26th and 27th. That's a Friday, Saturday. We're going to have a lot of fun. If you guys enjoyed some of this, you're going to love that.
Yeah, this is a really good investment, you guys. The cost is super low. I in no way benefit from this. Just so everybody knows that. They've given you guys a discount on Dental Sleep Profits behalf. So I highly recommend you guys take advantage of this online course. The value you're going to get is incredible. And I think, is it Mona Patel that's going to be speaking?
Yep.
Okay. Yeah. So
Mona, myself, and Chad.
Okay.
Mona is the nice one. She's our resident dentist. She's our lead clinical faculty here at A2S. Chad is our director of ops. So he's going to talk to you about screening and systems. And I get to talk to you about fun stuff like verbiage and clinical treatment plans and HST reports, things with my sleep tech background. Yeah. Bottom line, highly endorse it. I don't care if you've been to other sleep courses. We welcome that, guys. There's a lot of great educators out there. I think you would be surprised at how engaging this is for a virtual Zoom course. You're on camera, you're on mic, you're talking. We have breakout rooms, smaller audiences, no slides. We're dialoguing. It's group
and
learning.
You said up to 4 team members can come, right? Including
Correct.
on top of the dentist.
Yep. Dentist plus 14.
Yeah, $597 for that much education, you guys. You got to do this. This is a huge value.
So for those of you that are naysayers or you are not ready to do a course, that's fine. You can schedule a call with one of us. We're happy to take your questions, those burning questions that you don't ask here in a group forum. We're happy to talk practice specific stuff. We'll give you 25 minutes of time, answer any question that you have, and give you recommendations on what to do. We want to help people. That is the heartbeat of our business. You don't have to pay us to do that. But candidly, if you are wanting to grow your program, level it up, I would really strongly recommend the course. One other thing, if you cannot make August, register for August and we will move you for free. And I just broke everything that my team will smack me for tomorrow. But if you want to do the course and you're not sure about the August dates, get the discount and we'll move you for free.
Yeah.
That's not a problem.
And for those of you who have never, maybe just going out on a limb here, if you've never seen a QR code, you guys just hold your phone, turn the camera on and hold your phone up to the screen on whichever of these apply to you. And it should open a link for you guys. So that's why it says like phone scan here. Basically just open the camera on your phone, point it at one of these essentially barcodes.
Yep.
So
cool. Thanks for that. I never explained that actually. It'll take you to that, guys. That should be the screen that you see.
Yeah.
Okay,
then,
Chad.
Yeah, Chad just posted in the chat to get your
Awesome.
CE. We got a link there. And he also posted the link in the chat if you guys want to register for that course. Again, you guys, $597 is a very, very small investment. Sorry, I got the sun coming in my office into my eyes right now. But it's an incredibly small investment. You guys are going to get a ton of value from people who have a lot of experience in this industry. And you know, I've paid 10 times that cost for courses that I've gotten just one gold nugget from that have paid for themselves 100-fold. So if you guys just take away one gold nugget from that weekend course or your team, and that's the important part is like, if this just helps your team get on board with things, then it's such a huge value. Like how many appliances would you have to deliver to pay for $597?
Mm-hmm.
A third of an appliance?
Yeah.
Like it's just a huge value.
Yeah.
And I hope as many people as possible sign up. Again, I get no kickbacks from that. I just know value when I see it. It's the reason I teamed up with Awaken2Sleep. It's the reason I trust them. And a lot of other dental sleep profits clients trust them as well. Even into the executive level coaching, things like that, where Michael and Chad can help you guys transition your business from sleep as an adjunct to sleep as the only service you provide, if that's something you're wanting to do in the future, as a retirement or a hobby, or just make it your primary business altogether. So lots of opportunity there. So yeah, let's hop into Q&A.
Yep, let's do it. I saw one come in from Dr. Guros, Joseph. Basically, the physical demands of dentistry part, but he said, unfortunately, staff has really diminished in number. Mm-hmm. So that was kind of the question of how do we do this is what I got, correct?
Yeah, I think that was in the chat.
Okay. So I would say there's functional versus optimal. And we always need to start with functional. So frankly, Doc, if you've got the knowledge and you've got one person who's on board, start there and hone that in and then expand to the other team roles. If you have 5 people and that's your core and you're in a giant office, start with what you've got and get to the first step with any program is you've got to get functional. How do we functionally accept patients, treat patients, test patients, screen patients? How do we do this? Basic bare bones system. And then from there, you can do bolt-ons. You might long-term hire a sleep champion or a sleep queen or whatever you call them in your office, right? That you may have a full-time sleep person, but you're not going to start there. So what's functional for you today, that may be a unique situation for you versus other folks. I know I can speak to two different people on this call that are both dear friends of mine. Lily is on here tonight. Her and her husband, George, are the ones that are going from GP to DSM only. And then Tony, who I've poked fun at all night because he has a Southern accent and he's highly sarcastic on all of our stuff that he attends. He is doing GP as an associate and he's building his DSM only practice. So his functional with him and his sleep champion person is going to be totally different than if he had a pool of his own GP patients to go screen. He doesn't have that. So my encouragement to you guys, sorry, that's a very long answer to a short question. Whatever your next step is, do that, make it functional, and then go towards optimal. Because if you can create the roadmap of here's where I want to be, but here's where I'm at, if you don't know how to put that map together, lean into somebody that does. We do that. You might have somebody else in your backyard that you can go trust and go talk to a sleep dentist that's done this for 15 years. Awesome. Figure out what the map is and get to the next step, which is functional for your program, and then keep moving it along to get to the next spot.
Yeah. Okay. So some of the objections that people were typing, CPAP is working for them, then
Yeah.
You would just tell them to continue down that pathway. It's the gold standard, right?
Absolutely.
Yeah.
Yep.
Okay. Tony said money doesn't seem important. Lots of money. What do you do when the patient says no? What does my insurance pay?
My first question is, do you take insurance? And I didn't say, are you in network getting screwed sometimes by insurance, but do you take it? If you don't bill insurance and you're giving your patient a paperwork packet to submit on their own, your answer to that question is completely different.
Okay.
So
I know particularly in this doctor's case that the patient is the one who would help the patient submit the claim. They're not submitting it for them. So
got it.
Yeah.
So in that case, the answer is, this is the treat. So you came and said, hey, what does my insurance cover? Well, that's going to actually depend on your insurance and your specific plan. So what we can do is, in our circumstance over here for your treatment, we can get you set up with a payment plan that's as low as, let's say it's $3,500 round, like treatment plan, $147 a month, $147.50 for the next 24 months. We're going to pay your interest on that. It's care credit. As long as you pay it off within 24, you have no interest. We're going to take care of that part. This is how we get you going to start. So the next step to start the process is to do this. Now, you don't have to make all those payments. We're going to help you submit to your insurance, and they're going to process it based on your benefits. Your deductible, your co-insurance will give you everything that you need to submit to them, and we'll help you along the way as much as possible. In this scenario, Todd, when they're cash like that or fee for service and helping submit the claim, the next step isn't sign up for care credit or Sunbit or whatever the answer is, or insurance. In order to move from here to taking impressions, we need to get you on a payment plan. This is the next step, period. Right. If your insurance covers it, they pay for the whole thing. That part doesn't matter. So those things are not in opposition. The next step in order to move forward is to do this. I don't want to make 24 payments. No problem. You can make it faster. You can pick a different payment plan. That's your call. We just want to make it as affordable as possible, and you're not paying anything to get those payments. So if you get 2 bills and your insurance cuts you a check, you can pay that off or go to Hawaii. It's totally your call. It doesn't matter to us. In order to move forward, this is the next step.
Yeah. And would you connect that back to the emotional decisions the emotional things that they said were important to them about doing something about their situation? Or would you?
It depends on how they asked. If it was they're coming against it, then I would need to reconnect back to why they're doing this.
Okay.
If they're just asking an operational question of, hey, well, I want to know what my insurance is going to cover. Hey, I don't blame you. We pay a lot for our SIGINT insurance. All of us do. And they should be paying for as much as they need to be paying for. In our process, the next step is we need to get you signed up for one of these payment programs to make it affordable. But in addition to that, we're going to give you all the paperwork and the codes. You can check with your insurance. We're going to help you submit this process. Now, we can't guarantee they're going to pay. You know that. We know that. We don't bill them, but we're going to give you everything you need to bill them. And whatever they pay you is based on your plan.
Yeah.
So next step is this. It's not in lieu of your insurance. Your insurance is the next step after that. So we have to do this first to get you to the point of treatment. By the way, your insurance won't even process a claim until we've done the next step and delivered your appliance. That's when we can give you the paperwork packet to submit to them that you've actually received the appliance. That's the only time they'll actually process this.
Perfect.
So if we don't do it, again, confrontation versus collaboration, insurance is just a future step past getting a yes for financials in that scenario.
Mm-hmm.
Flip the coin. Since money was such a big deal, I don't want to move on from it here. Flip the coin. Now we're in a practice like Lily's, that bills medical, that gets gap exceptions. So they're in network on their out of network rate. Being able to talk to the patient about that and having a clear understanding of what does this insurance plan typically allow? What is the typical out-of-pocket cost? And telling the patient that. And having, please have on your written signed treatment plans from the patient, the total dollar amount of the treatment that you're billing to medical, their estimated portion, and some fine print on the bottom that says they are financially responsible for the entire treatment should their insurance not pay or accept blah, 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 blah. Guys, every single time you go into the physician's office, you sign that form electronically. Every single time you are financially the guarantor of services if your insurance does not pay. It's just way bigger. Please have them sign a document like that, even if you bill medical and you're getting gaps in network, all this stuff.
Yeah. Okay.
I know that's really in the weeds, but that stuff matters.
Yeah. Yeah.
Absolutely. Or it doesn't matter till it really does. And then it really sucks. Oh, yeah.
Okay. So we've covered the what does my insurance cover, or it's too expensive. I think you've covered that. You know, you're either gonna it's pay now or pay later, or pay a lot more later. I think you did a good job of explaining that. Does my insurance cover it? They don't want to take a sleep test because they don't think they have a problem. What do you do there? Is that a communication deal? You've not communicated the problem well enough?
So that's Michelle's question, right?
Yeah.
Michelle, I would say there's two different kinds of patients you're talking to with that. They are either stubborn and creating confrontation and pushing back. I already told you I don't have a problem sleeping. You give me 5 minutes, I can fall asleep in this chair, watch. Like, that's stubborn confrontational. The way you handle that is very different from a patient that says, I don't really think I have a problem. Totally different answers. Stubborn one, I would say you're coming in and saying, again, trying to collab, shoulder to shoulder. I'm your doctor, I'm your dentist. Other patients that present with these signs that I'm seeing in your mouth, the health history that you have, these are clinically relevant, and we need to find out what's going on with your airway. This is why you need to test. You don't have to do the test with me. We're basically covering our costs to run the test here. This is not, we don't make a living on these tests. I had to buy this equipment and we basically give the test away. But please, you don't have to deal with us. Go ask do you have a primary care? You want me to send this questionnaire and my chart notes over to them so that way they can order a test? What would you prefer? I just want you to get a test. It's not about me selling you anything today.
Yeah.
I think if we take the iron out of the fire and really clearly say, this is not how I make a living. We basically do this at cost to help our patients. You could take, hey, it's a free oral cancer screening. You want to go pay somebody to go do this in your mouth somewhere else? No problem. But this one is free. You know, like, that shouldn't be a resistance. If it is, then you're looking at somebody who doesn't want to know. They're at the point in their learning ladder, they're afraid of what they don't know because it might make them change. So somebody that's resistant like that, one more piece for Michelle, I would also say that if they're pushing back and they're like, I really don't think I have a problem because, okay. So
Yeah.
if we don't do this and you have it, this is what happens. This thing that hurts, whatever that is, just continues to get worse until.
Yeah.
That's what we're trying to avoid.
Okay.
So we're just trying to get more. I don't know that you have it. We're trying to get more information to see if there's anything going on. If there is, we can talk about that. There might not be, but we need to find out more information.
Okay.
Yeah.
What do you do when potential patients that you contacted, all they want is information? They don't want a consultation. They don't want any of that.
They just want information.
Yeah.
Like they
Would
responded
you
to
ask
one of your amazing ads
Yeah.
and they just want to call and fish. Right?
Yeah. Maybe they just want to call. How much is it?
Yeah. Do you
just give them the
these?
cost?
Oh my gosh, no. Are you kidding me?
I've seen that. I've seen that. I've seen that.
Please, okay, guys and gals on this call, please don't do that. This is not a vacuum cleaner. Are you kidding me? This is a customized treatment for your patient. This is not a piece of plastic. It's a however long you warranty it and do adjustments treatment plan. If someone called you and said, hey, how much is an implant? Which one? Do you need a bone graft? Am I doing an extraction? Do you have a hole? Is it number 9 or 19? Like that's is it quadrant dentistry? Do you have mobile teeth around it? You have perio disease? Are you kidding me? You're not going to quote them for an implant over the phone. If you are, you shouldn't. Please stop. Yeah. That's my honest answer as your new friend. And that's what Todd poked me right now to do without saying it, that please don't do that. You're not Walmart. It's not a vacuum cleaner. If you're going to act like a doctor, dentist, you're doing a treatment plan, we got to act like that.
And we need to coach our staff
yes
on how to answer that question. Because oftentimes it's not the doctor, because that patient maybe it's responding to an ad that Dental Sleep Profits is doing for you, or maybe it's just a response to a Facebook post that you guys did. And it's your staff that's answering that question. And I've actually seen this mistake where people just say, oh, it's 3,500. Okay, thanks.
Yep.
Like you did not do that patient a favor.
And I got to be honest, like right now I'm being a little bit strong, aggressive. Let's put it this way, guys. If we're working with your team, we're not pounding Tony, we're not pounding Lori. Lori, you're not in danger if you've ever done that. But here's the thing. We want to equip you with the right verbiage. So here's a snippet. Hey, you know what? We wish we could quote you over the phone. The honest answer is we can't. There's multiple types of apnea, different severity levels, and there's also multiple appliances. At the end of the day, that's doctor's discretion based on your type and severity of apnea. Are they comfortable treating you under a physician's direction? And if they are, what appliance they pick is 100% theirs. So I can't even give you an answer with that. That's why boom, here's the answer, pause, redirect. That's why we give every incoming patient a complimentary telemedicine consultation or a reduced fee, $50, $49 consultation to spend time with the doctor. You can schedule an appointment. We can get you in and they will review your sleep test. They will review what the physician has ordered. They will review what type and severity of apnea, go over your appliance options, blah, 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 blah. Insert your plug. If you don't have a place to point them when they ask you about price, you have a problem. So give them a holistic answer as to why clinically it would be inappropriate for you to quote them a fee over the phone, then redirect them to where they actually belong, which is what you're trying to do with those ads.
Yeah. That's a great answer. Okay. Dr. Linder asked, do you push them away in the close or just ask and assume they're going to do it? Like I think we talked about this a little bit on the last webinar, Michael, about the presumptive close.
Mm-hmm. Yeah.
Is that how you would recommend generally approaching it? Like, I'm the doctor. Here's our next step. I'm going to order a sleep test for you in the state of Oklahoma. I'm allowed to distribute sleep tests, yada, yada, yada. Do you just presume they're going to do what you say?
No,
Okay.
but let me be clear too, just for clarity. I'm not a doctor. I'm not an MD or a DDS.
Right.
I'm a dude who's been in sleep medicine for 20 years. So I've seen a lot of MDs do this and DDSs. So I'm coming from I haven't said this to a patient in my practice. I want to be clear with that. The way that we coach doctors to close like this is you have to have already built the connection with the patient to do anything that is considered a push. And the more you distance yourself from the money, the more you can push as their doctor. Like my dentist I've known for, I'll give you my personal example. I've known him for almost 17 years. Steve is my sushi friend. Every time I walk in, it's 100% sarcastic and we're high-fiving and goofing around. That guy is not going to dance around. Well, in the state of California, Mike, you've got to understand that as your dentist, are you kidding me? Like, come on, man. Be real with me. Be frank with me. Talk to me like you normally do. So Todd, to answer you, and Leo, to answer you, I'm going to say this. You know your patients. There's some people that you need to be sharp with, like me as your patient. And there's also ones you're going to need to be gentle with. You may know that this person never, ever makes a decision on the spot because they take 2 days to process everything. That's who they are. Hey, you know what? Leo, you're going to say, look, hey, Linda, I understand this is a lot to take in. What I'd like to do is I want you to consider all of the things that I've said. This is the doctor's recommendation. Here's my recommendation. I want to make sure that we do something about this and I'm here for you. Let's make sure we have an appointment on the books for 7 days from now. Let's do it 1 week out. Let's make our schedules work. Tina can help you up front. Let's lean into your folks. Please don't hear something tonight and go, that's the one way I do it. It's not. The principle informs the practice. So take what I've talked about tonight in principle form and morph it into how you know your patients operate. End statement. I'll make a separate one. Please don't ever apologize for being their doctor. And I know doctor, dentist, some people use it interchangeably, some don't. I'm not impartial either. I'm not partial either way. But let me tell you, you're a licensed provider and this is your scope of practice. You should never have to apologize for recommending, clearly stating your recommendation for treatment or diagnostics within your scope of practice. Don't dance because it just looks like a lack of confidence. You need an x-ray because I understand you don't like radiation. This is really minimal radiation. It's digital. Here's all the things we've done to meet people where they're at like you. You need an x-ray, period. Why is a home sleep test weird? Just because it's new.
Yeah.
Yeah.
Okay. That was a great answer, Michael. Okay. Someone asks, is Mona Patel no longer with Sleep Group Solutions? I don't know the answer to that.
She's not speaking for them any longer. That was a season for her, and she's our current lead clinical faculty.
Okay, cool.
Yeah.
And do you happen to know, I know Chad might need to pipe in here, do you know future dates past August?
Yes.
Of your weekend courses? Can you maybe Chad can type those in the chat?
Yeah, Chad.
Something.
September 23rd and 24th, Dr. Joseph. September 23rd and 24th is the next one after August. October, I want to say it's the 21st and 22nd. Whatever that weekend is, it's a Friday, Saturday. Okay. Chad can hit us up in the chat for those. Yeah. But yeah, like I said, if you guys are really interested in the course, and Dr. Joseph, to your point, you're trying to grab some more staff to get them in, totally respect that. You're welcome to attend by yourself and then send them to a later course for free as part of that ticket, or you could get the discounted ticket and just move it to a different date. You don't have to have that date lined up in the beginning. We want to work with you guys. That's the truth. We don't want to push. we'd love to be here to serve you and help you serve your folks. And if that's beneficial, great. If it's, look, if my voice sounds like nails on a chalkboard, please don't register for a course. You're going to get more of this on that weekend.
I think it's Barry White smooth. I don't know what you're talking about.
It's the low.
That's right. And it looks like,
oh my gosh, it's 9:30, man. We got to wrap this up.
Yeah, we got to wrap it up. Michelle signed up for the class in August. Awesome, Michelle. Good decision. Michael, thank you so much for coming on, sharing just an absolute wealth of knowledge. And I'm sure we're going to be doing this again someday.
Yeah. So, thank you, man. And guys, can I leave a closing remark here?
Go for it. Go for it, buddy.
Not like you haven't heard me enough tonight. Keep going, please. Because if you think about all the folks that are in front of you, the ones that have said no, the ones you haven't talked to yet, they're worth it. And the circles in their life who would actually miss them, to Tony's question, it's worth it. So if you're in a spot where you're struggling, you're frustrated, you don't have the people you need or the stuff or the tools, this is the 14th time you're trying to do this. Just know, go back to your why, maybe tweak some things on the how and the what you're trying to accomplish, but go back to the why. That will center you on this does matter, and find your way. And seriously, if there is something that we can do, whether you pay us for it or it's a free coaching call, we are truly here to help you wherever you're at in your process. Just like Todd's a wealth of knowledge on his side. We're on our side. We're folks coming together to try to be your tool set. So use this how you can and know that it's worth it.
Yeah. All right, you guys. Thanks again, Michael. Thank you, Chad. And we're going to sign off. Everybody, take action. You know, there's a lot that was learned here tonight, a lot that was shared. Implement. I know dental sleep medicine can be frustrating at times, just like general dentistry can be frustrating at times, but keep pushing that rock up the hill, and eventually it hits that crest and it'll start rolling for you. And like Michael said, if Awaken2Sleep can help you guys get that ball rolling in that direction that you're wanting it to go, reach out. Honestly, reach out to them. Schedule that 25-minute call. The fact that they're offering 25 minutes for free just to help point you in the right direction or help you create a blueprint is incredible. If you want to reach out to me and talk about accelerating that process through advertising, let's do that. Whatever you guys need, we're here. Just give us a ring. And this recording is going to be posted on the Dental Sleep Profits YouTube channel as well. If you guys are not, I think everybody here is on my email list, so you're going to be getting the recording. If not, yeah, check out Dental Sleep Profits YouTube channel, and it will be posted there by the end of the week. So, Michael, thanks again. Good night, buddy. Yeah. It's late. Go be with your family.
Awesome. Thanks, man. Have a great night, guys.
You too. All right. Good night, everyone.